Upper Respiratory Problems, Chapter 27 from the Lewis textbook. This is a review from class. Epistaxis is also known as a nosebleed. It's important to do the ABCDs, assess for airway, breathing, circulation, and disability. Look for respiratory distress and for tolerance of packing or tubes. Giving humidification, oxygen, bed rest, antibiotics, pain medications would probably be advised. The patient's airway could be compromised by any bleeding, and this is why airway is going to be the highest priority assessment. If a patient has a posterior nasal bleed, they could quickly lose a lot of blood. So a posterior nasal bleeding would be an emergency. The first action for epistaxis is to apply direct pressure by pinching the nostrils. Application of cold packs could help decrease blood flow to the area, but it would not be sufficient to stop bleeding. Older patients with nasal packing, now they're at risk for aspiration or airway obstruction. If the interventions don't work, then the affected capillaries are cauterized with silver nitrate and then the nose is packed. Allergic rhinitis. The nurse should clarify that nasal decongestant spray should be used for no more than 3 days to prevent rebound vasodilation and congestion. An important intervention is to assist a patient in identifying and avoiding the potential allergens. Intranasal corticosteroids, now not oral antihistamines, should be started several weeks before the allergy season. The corticosteroid nasal sprays have minimal systemic absorption, and non-sedating antihistamines are available over the counter. Displacement of either the bone or cartilage of the nose can cause airway obstruction or cosmetic deformity and is a potential source of infection. A cerebral spinal fluid leak could indicate a skull fracture. Nasal fractures represent the third most commonly broken bone in the body, and the nose is the most commonly broken facial bone. In prioritizing care, airway is the first priority. If a patient cannot breathe through the nose after surgery, it's usually because the nares are packed and taped. Remember that these patients are not able to blow their nose. Part of nursing care would be to encourage rest and use of cool compresses on the nose, eyes, face, and help reduce the swelling and bruising. They may need some pain medications like acetaminophen. It is not recommended to give nonsteroidals for 48 hours after a nose injury. After a rhinoplasty, repeated swallowing could indicate a patient is experiencing posterior nasal bleeding, and as we've already talked about, that could be an emergency. Immediate intervention is necessary because you want to prevent hemorrhaging. Now, this is a difference between expectation versus complication. Swelling and bruising are common after surgery. Upper airway obstruction. Life-threatening emergency in which an interruption in airflow through the nose, mouth, pharynx, or larynx occurs. Early recognition is important to prevent further complications, including leading to respiratory arrest. Causes of acute upper airway obstruction include viral and bacterial infections, fire or inhalation, chemical burns, allergic reactions, foreign bodies, and trauma. The blockage could be complete or partial. A mild obstruction might result in air hunger, while a more severe obstruction could lead to cyanosis, confusion, or unconsciousness. Complete obstruction, if not corrected, could lead to rapid suffocation and death. And the interventions include assessment for cause of the obstruction, maintenance of a patent airway and ventilation, and the patient may need cricothyroidotomy, endotracheal intubation, or tracheostomy. The patient who is status post laryngectomy should be taught alternate methods of swallowing, such as supraglottic swallowing. Influenza. Current guidelines suggest healthy individuals between 6 months and age 49 receive intranasal immunization with live attenuated influenza vaccine. Individuals who are pregnant, residents of nursing homes, or are immunocompromised or have a chronic medical condition should receive inactivated vaccine by injection. The flu is spread by virus-infected droplets that are coughed or sneezed into the air, and the flu is contagious. People infected with the flu are contagious from a day before they feel sick up until their symptoms are resolved, usually about 1 week for adults, but can be up to 2 weeks for young kids. Practical ways to prevent the spread of the flu: wash the hands thoroughly and frequently, never pick up used tissues, and never share cups and eating utensils. The expectations from influenza would be myalgia, headache, mild temperature elevation, and sore throat with cough. And usually these are treated with supportive care measures like over-the-counter pain relievers and increase their fluid intake. Complications could be crackles, which could indicate the patient may be developing pneumonia, which is a common complication of influenza, which would then require aggressive treatment. The flu is often confused with the common cold. but flu symptoms are usually more severe than typical sneezing and stuffiness of a cold. The signs and symptoms includes fever plus one or more of the following: a cough, sore throat, body aches, headache, chills, fatigue, diarrhea, or vomiting. Patient could be tachypnic, dyspneic, cyanotic, lethargic. After 5 days, fever and other symptoms usually disappear, but a cough and weakness may continue. All symptoms are usually gone within a week or two. Sinusitis, usually Tylenol for comfort. Avoid nonsteroidals. Keep the patient well hydrated. Watch for color changes of nasal secretions or sputum. Steam and a hot shower will help thin the secretions and improve the drainage. Sterile saline can be used to thin and remove secretions, and it can be made at home. Nasal decongestion should not be given more than 3 days to prevent rebound vasodilation and congestion. Raising the head of the bed will help decrease sinus pressure and decrease pain. Blowing the nose after a hot shower or using saline can help expel those secretions. Pharyngitis is one of the most common respiratory tract infections. It usually involves inflammation of the central region of the pharynx known as the oropharynx. Because the tonsils are attached to the oropharynx, pharyngitis commonly involves tonsillitis. Signs and symptoms are red pharyngeal membrane, white-purple flecked exudates, enlarged and tender cervical lymph nodes, fever, malaise, sore throat, difficulty swallowing. A cough could be absent. Viruses are the most common cause of pharyngitis, and many different viruses can cause this. Acute pharyngitis will see anterior cervical lymph node swelling, most likely a temp. Red or yellow patches. Would need to have a strep test or cultures to determine if patient has streptococcal pharyngitis. Oral or pharyngeal fungal infections are treated with nystatin solution, and the goal of the swish and swallow technique is to expose all of the oral mucosa to the antifungal agent. The tonsils are lymph nodes in the back of the mouth and top of the throat. They normally help to filter out bacteria and other microorganisms to prevent infection in the body. They may become so overwhelmed by bacterial or viral infection that they swell and become inflamed and cause tonsillitis. The infection may also be present in the throat and surrounding areas, causing inflammation of the pharynx. So the signs and symptoms of tonsillitis: think sore throat and mouth breathing, fever, difficulty swallowing, enlarged reddish tonsils, and foul-smelling breath. Peritonsillar abscess forms in the tissue of the throat next to one of the tonsils. An abscess is a collection of pus that forms near an area of infected skin or other soft tissue. The abscess can cause pain, swelling, and a severe blockage of the throat. If the throat is blocked, swallowing, speaking, and even breathing become difficult. When an infection of the tonsils, tonsillitis, spreads and causes infection in the soft tissues, a peritonsillar abscess may result. A patient's clinical symptom you might see is called a hot potato voice, and this suggests a possible peritonsillar abscess that could lead to an airway obstruction requiring rapid assessment and potential treatment. Laryngitis is the inflammation of the larynx. It causes a hoarse voice or the complete loss of the voice because of irritation to the vocal cords. Usually, this is caused by an upper respiratory infection like influenza or the common cold. A bacterial invasion may be secondary. This is predisposed by vocal overuse, smoking, alcohol intake, and irritant gas inhalation. Although it sounds odd, sometimes the stomach can cause laryngitis. The stomach acid that helps break down the food comes back up the esophagus. The acid then irritates the vocal cords. So a horsey or raspy voice is a main symptom or sign of laryngitis. There may be no voice at all, and maybe just a little squeak come out when they're trying to talk. Coughing to clear the throat, or they might feel a tickle deep in the throat, may be signs of laryngitis. Now, polyps can hinder inhaling, and this can cause chronic head pain as a result of lack of air. May also end up yawning a lot, as well as encounter daytime exhaustion, even after an appropriate night of rest. The patient may not be able to smell or perhaps taste as effective as they used to. Nasal polyps are usually benign, grape-like swelling of the mucous membranes of the sinuses that form from repeated inflammation of the sinus or nasal mucosa. The nasal polyps obstruct breathing and can block sinus drainage. The first-line treatment for nasal polyps is a nasal corticosteroid. In many cases, they'll shrink or even eliminate the nasal polyps. In other cases, a 1-week taper course of oral corticosteroids like prednisone might be necessary. Unfortunately, nasal polyps tend to reoccur if the underlying irritation, allergy, or infection is not adequately controlled. So it may be necessary to continue using a corticosteroid spray to try and prevent the nasal polyps from returning. Otherwise, surgery would be the treatment of choice, and again, the polypectomy. Xerostomia, dry mouth, makes it hard for a person to eat, talk, swallow, wear dentures, or taste food. In many cases, home treatment will relieve the symptoms of a dry mouth. An ongoing dry mouth can lead to mouth infection, gum disease, and dental cavities. Some cases of dry mouth include dehydration, breathing through the mouth, stress, anxiety, smoking, or problems of how the salivary glands work, so a patient makes less saliva. Low saliva production is common as a person gets older, but it can be partially alleviated by drinking fluids at frequent intervals. Radiation will damage tissues at the site being radiated, so frequent oral rinsing with a non-alcohol-based rinse is recommended. The effects of radiation therapy. Prolonged alcohol use and smoking are associated with the development of laryngeal cancer. Family history is not a risk factor for head or neck cancer. Keeping a patient in a semifallus position would decrease edema and limit tension on the suture lines to help ensure an open airway. Herpes zoster is a clinical syndrome that occurs when latent varicella zoster virus is reactivated from dorsal root ganglia. Patients with cancers of the head and neck are at significant risk for regional herpes zoster. The morbidity of zoster in the head and neck can be severe, including encephalitis, blindness, deafness, and debilitating post-herpetic neuralgia. The risk of such morbidity can be reduced with prompt initiation of therapy on diagnosis. However, the diagnosis of zoster can be missed or delayed following a head and neck reconstruction. Subcutaneous emphysema occurs when there is an opening or tear in the trachea and air escapes into the tissue under the skin. Air can also progress through the chest and other tissues into the face. Inspect and palpate for air under the skin around the new tracheostomy. Physical assessment will generally reveal edema of the affected area along with subcutaneous crepitus, which is a crackling sensation under the skin during palpation. While palpating the involved area, use a skin marker to identify its borders, and this will help determine whether the subcutaneous emphysema is progressing or resolving. If the skin is puffy and you feel a crackling sensation, notify the physician immediately. It's important that you remember that if subcutaneous emphysema involves the patient's neck or upper chest, their airway patency may be compromised. Frequently assess the patient for signs and symptoms of respiratory distress, including tachypnea, dyspnea, tachycardia, decreased or absent breath sounds, and use of accessory muscles. Edema in the neck or upper chest could compress the trachea and cause airway obstruction and require emergency endotracheal intubation or a tracheostomy. If the patient develops respiratory distress, then the rapid response team needs to be called and be prepared to assist with emergency interventions. A tracheostomy is a surgically created stoma in the trachea to establish an airway. The advantages of a tracheostomy versus an endotracheal tube is that it provides a more secure airway and is less likely to be displaced. It allows more freedom of movement than an endotracheal tube. There is also less risk of long-term damage to the vocal cords. Airway resistance and work of breathing are decreased, facilitating a more independent breathing. Patient comfort may be increased because no tube is present in the mouth. Eventually, the patient may be able to eat with a tracheostomy because the tube enters lower in the airway. Speaking is also permitted once the tracheostomy cuff can be deflated. A variety of tubes are available to meet individual patient needs. All tracheostomy tubes contain a faceplate or flange which rests on the neck between the clavicles and the outer cannula. In addition, all tubes have an obturator which is placed when inserting the tube. During insertion, the obturator is placed inside the outer cannula with its rounded tip protruding from the end of the tube to ease insertion. After insertion, the obturator must be removed immediately so airflow can flow through the tube. Keep the obturator at the bedside in case of accidental decannulation. Some tracheostomy tubes also have an inner cannula which can be removed for cleaning. The inner cannula can be disposable or non-disposable. Both cuffed and uncuffed tracheostomy tubes are available. A tracheostomy tube with an inflated cuff is used if the patient is at risk of aspiration or needs mechanical ventilation. An external pilot balloon provides a visual of internal cuff inflation. The inner cannula can be disposable or non-disposable. If disposable, replace per manufacturer and institutional guidelines. If non-disposable, the inner cannula is cleaned at least every 8 hours. Cleaning removes the mucus from the inside of the tube to prevent airway obstruction. If humidification is adequate, the mucus may not accumulate, and the tube without an inner cannula can be used. Change the tracheostomy ties as needed. A tracheostomy tube holder can be used in place of twill ties to make a tracheostomy tube stabilization more secure. A two-person technique, you need one to stabilize a tracheostomy and one to change the ties. It's best to ensure that the tracheostomy does not become accidentally dislodged during the procedure. Place 2 fingers underneath the ties to assure they are not too tight around the neck. Do not change the tracheostomy ties for 24 hours after the tracheostomy procedure. Assess the need for suctioning. Indications would include coarse crackles or rhonchi over large airways, moist cough, increase in peak inspiratory pressure on a mechanical ventilator, and restlessness or agitation if accompanied by a decrease in SpO2 or PaO2. The patient's mouth and trachea should be suctioned before the cuff is deflated to prevent aspiration of the oral secretions. The amount of air needed to inflate the cuff, that varies, and it's adjusted by measuring the cuff pressure or using the minimal leak technique, not by measuring the volume of air removed from the cuff. The cuff is deflated during patient exhalation so that the secretions will be forced into the mouth rather than aspirated. There is no need to clean the inner cannula before cuff deflation. Suctioning longer than 10 seconds can cause cardiopulmonary compromise, usually from hypoxemia or vagal overload. If resistance is felt after insertion of the catheter for a maximum recommended distance, the catheter has probably hit the carina. Pull the catheter back 1 to 2 centimeters before applying suction. Application of suction pressure while the catheter is introduced into the trachea increases the risk for damage to the mucosa. The length of the catheter that should be inserted depends on the length of the tracheostomy tube, but 5 inches would be appropriate for most adult patients. If the trach tube comes out, then insert a new tube. Avoid them eating a meal when they're tired because it would put them at risk for aspiration. A chin tuck is used to help prevent aspiration when they do eat. If a patient is on a ventilator, the use of a closed system suction catheter is preferred in order to minimize the breaks in the system and decrease the risk of ventilator-associated pneumonia. Non-sterile gloves are worn during suctioning procedures as sterility of the suction catheter is maintained within the closed system. Hyperoxygenation. It provides some protection from suction-induced decline in oxygenation. It is most effective in the presence of hyperinflation, such as encouraging the patient to deep breathe or increasing ventilator tidal volume settings. To insert a new tube, replace the old tracheostomy tube with a new tube. Some experienced nurses or respiratory therapists may be able to do this quickly and reinsert a tracheostomy tube. Always keep a spare tracheostomy tube of the same size and maybe one size smaller and same type at the bedside in event of emergency replacement. Notify the physician after reestablishing an airway, and be prepared to manually ventilate a patient if respiratory distress develops. Tracheomalacia. The trachea is soft and floppy rather than rigid, and usually due to a birth defect. In adults, tracheomalacia is generally caused by injury or by smoking. Can occur when the cuff is overinflated. The ability for phonation increases when the cuff is underinflated. Tracheoesophageal fistula. An abnormal channel forms to connect the trachea and the esophagus, so the passage of swallowed food from the esophagus goes into the trachea and causes serious lung problems. Now this can happen if the cuff is overinflated. The trach cuff must be completely deflated by evacuating all of the air before the tube is capped. The decannulation cap is then put in place to allow a patient to breathe through the fenestrations and around the tube. The cuff is deflated and the inner cannula removed to allow air to flow across the patient's vocal cords when using a fenestrated tube. Both cuffed and uncuffed tracheostomy tubes are available. Tubes with an inflated cuff are used when there's a risk of aspiration or in mechanical ventilation. Inflate the cuff with the minimum volume required to create an airway seal. It should not exceed 20 milliliters of mercury or 20 centimeters of water in order to prevent a tracheal necrosis. A fenestrated tube has openings on the surface of the outer cannula that permit air from the lungs to flow over the vocal cords. Only patients who can swallow without the risk of aspiration can use this tube. The inner cannula can be fenestrated or non-fenestrated. Use a non-fenestrated inner cannula when suctioning to decrease risk of tracheal damage caused by the suction catheter going through the openings. Before using the fenestrated tube, determine the patient's ability to swallow without aspiration. If there is no aspiration, remove the inner cannula, if non-fenestrated, deflate the cuff, and place the decannulation cap in the tube. It's important to perform the steps in order because severe respiratory distress may result if the tube is capped before removing the inner cannula and deflating the cuff. When a fenestrated cannula is first used, frequently assess the patient for signs of respiratory distress. If the patient is not able to tolerate the procedure, remove the cap, insert a non-fenestrated inner cannula, and reinflate the cuff. A disadvantage of fenestrated tubes is the potential for development of tracheal polyps from tracheal tissue granulating into the fenestrated openings. As you can see here, the fenestrated tube has a hole, and it's used to promote airflow in speech, and one without a fenestration is used for suctioning. The non-fenestrated inner cannula is also used whenever the patient needs to be mechanically ventilated. A fenestrated tube is generally not recommended when cuff inflation is required to protect the airway from aspiration, because then a non-fenestrated tube is used. Monitor and record cuff pressure every 8 hours, and it should be less than 20 millimeters of mercury or less than 25 centimeters of water to allow adequate tracheal capillary perfusion. If needed, remove or add air to the pilot tubing using a syringe and stopcock. Afterward, verify cuff pressure is in accepted range with a manometer. You need to report if there's an inability to keep the cuff inflated or need to use progressively larger volumes of air to keep the cuff inflated. Potential causes include tracheal dilation at the cuff site or a crack or slow leak in the housing of the one-way inflation valve. If the leak is due to a tracheal dilation, the physician may intubate the patient with a larger tube. Cracks in the inflation valve may be temporarily managed by clamping the small bore tubing with the hemostat, and the tube should be changed within 24 hours. Cuff deflation. When a patient is not at risk for aspiration, the cuff could be deflated to allow the patient to talk and make swallowing easier. Before deflation, have the patient cough up secretions if possible and suction the tracheostomy tube and then the mouth. This step is important to prevent secretions from being aspirated during deflation. The cuff is deflated during exhalation because the exhaled gas helps propel secretions into the mouth. So have the patient cough and then suction the tube after cuff deflation. Assess the ability of the patient to protect their airway from aspiration. Remain with the patient when the cuff is initially deflated, and if needed, reinflate the cuff during inspiration. Retention sutures may be placed in a tracheal cartilage when the tracheostomy is performed. If present, tape the free ends to the skin in a place and manner that leaves them accessible if the tube is dislodged. Take care not to dislodge the tracheostomy tube during the first 5 to 7 days when the stoma is not mature because it's not healed. Because tube placement is difficult, several precautions are required. Keep that replacement tube of equal or smaller size at the bedside, and because that way it's available for an emergency reinsertion. Remember, do not change the tracheostomy tapes for at least 24 hours after the insertion procedure. And a physician performs the first tube change, usually no sooner than 7 days after the tracheostomy. So the tube is out. What do you do first? Immediately attempt to replace it. Grasp the retention sutures, if they're present, and use a hemostat to spread the opening to facilitate replacing the tube. Insert the obturator in the replacement tube, lubricate with saline poured over the tip, and insert the tube into the stoma at a 45-degree angle to the neck. Once inserted, remove that obturator immediately so that air can flow through the tube. If the tube cannot be replaced, assess the level of respiratory distress. Position the patient in a semi-Fowler's position to alleviate minor dyspnea. Severe dyspnea may progress to respiratory arrest. If this situation occurs, cover the stoma with a sterile dressing and ventilate the patient with a bag mask ventilation over the nose and mouth until help arrives. If the patient has had a total laryngectomy, there will be complete separation between the upper airway and the trachea. Ventilate this patient through the tracheostomy stoma. Initially, tracheostomy patients should receive humidified air to compensate for the loss of the upper airway to warm and moisturize secretions. Humidification is essential to help prevent retention of tenacious secretions and formation of the mucus plugs. Change the tube approximately once a month after the first tube change. Monitor the patient for potential complications such as airway obstruction, airway leak, altered body image, aspiration, bleeding, fistula formation, impaired cough, infection, subcutaneous emphysema, tracheal stenosis, tracheal necrosis, and/or tube displacement. When a tracheostomy has been in place for several months, the tract will be well formed. The patient can then be taught to change the tube using a clean technique at home. The patient with the tracheostomy who cannot protect the airway from aspiration requires an inflated cuff. However, an inflated cuff may result in swallowing dysfunction because the cuff interferes with the normal function of muscles used to swallow. So it's important to evaluate a patient's swallowing ability and risk for aspiration when the cuff is deflated. Clinical assessment of a patient's ability to swallow is assessed by speech therapists, video fluoroscopy, or fiber optic endoscopic evaluations. If the patient is able to swallow without aspirating when the cuff is deflated, the cuff may be left deflated or a cuffless tube is substituted. A speaking tracheostomy tube has two pigtail tubings. One tubing connects to the cuff and is for cuff inflation, and the second connects to the opening just above the cuff. When the second tubing is connected to the low flow, like 4 to 6 liters a minute air source, sufficient air moves up the vocal cords to permit speech. This device allows a patient at risk for aspiration to speak with the tracheostomy cuff inflated, but the speech quality is typically poor, with the patient barely speaking above a whisper. Specialized tracheostomy tube and speaking valves are available to facilitate speech, and advocating for the use of these devices will help provide psychological benefits and facilitate self-care for the patient with a tracheostomy. A variety of speaking valves are available that can be attached to the tracheostomy tube. These valves contain a thin plastic diaphragm that opens on inspiration and closes on expiration. During inspiration, air flows in through the valve. During expiration, the valve prevents exhalation and air flows upwards over the vocal cords and into the mouth, allowing a normal speech pattern. When a speaking tracheostomy valve is used, a cuffless tube must be in place, or the cuff needs to be deflated to allow exhalation. Prior to attaching a speaking valve, it is important to evaluate a patient's ability to tolerate a cuff deflation without aspiration or respiratory distress. Once the speaking valve is in place, carefully assess the patient's ability to breathe. The patient may initially only be able to tolerate short periods of use until becoming acclimated to exhaling through the mouth. Remove the valve immediately if the patient demonstrates any signs of respiratory distress. If speaking devices are not used, then provide the patient with paper and pencil or a magic slate. A communication board with pictures of common needs and an alphabet for spelling words is useful for patients who are weak or have difficulty writing. Decannulation. When the patient can adequately exchange air and expectorate secretions, the tracheostomy tube can be removed. The trach site will close on its own. A small dressing is placed over the site, and the dressing must be changed if it gets soiled or wet. Epithelial tissue begins to form in 24 to 48 hours, and the opening will close within 4 to 5 days. Surgical intervention to close a tracheostomy is usually not required.